So we're going to look at the anatomic injury patterns of common bile duct injuries. And let's talk about the problem. The problem is that bile duct injuries remain the most serious complication associated with laparoscopic cholecystectomy, and it is the most litigious. And this is something that is very, how can I say, enlightening. And I would like Jesse to comment on that. As you look through the literature, the range of common bile duct injury rates varies from 0.2 to 2.7. I mean, Jesse, I think this is absolutely extraordinary, and it has not changed over the last 10 to 15 years, unfortunately. And despite all that we've done in analyzing technical complications, the root cause remain elusive. Can you just give us a comment on why you think the ranges are so high? And I don't think we are as good as we think we are, and the learning curve is still going on.
It's a good question. It may be, a little bit out of my area of expertise to a certain extent. I'm not necessarily, I guess this is almost epidemiology as much as anything else. But I think that there's likely multiple factors involved. I think that, we have a workforce of surgeons that of varying levels of, training and skill and familiarity. Though I think that with the appropriate training that anyone, should be able to do, a laparoscopic cholecystectomy with, very excellent outcomes. I think that, there's a rate of human error involved in these things, right? And just like anything else. And that, a lot of the studies, a lot of your work has been, to try to reduce that human error. And it's why we have, checklists, and it's why we have, different technologies that get introduced to try to eliminate that human error. And we're not quite there yet. In order to completely eliminate the human error, we're not, like the pilots in a cockpit where we go through every single checklist before we take off and before we land. But I think we're getting closer to that. And maybe that is the next step. Maybe it's a combination of that and technology. I mean, if you talk to some of the, robotic developers for robotic surgery platforms, we may enter a time where, just like on, when I'm driving my car on the highway, if I'm going a certain speed and the car in front of me is too close, my car is going to start giving alarms that go off and tell me, hey, you might want to slow down, or you might want to hit your brake to prevent that accident. We may enter a time where on robotic platforms, where if you're getting too close to the main bile duct, there may be alarms that go off and buzzers that go off saying, you're getting too close. Don't cause an injury here. Are you sure you want to do this?
Well, I think I agree with you. It is multifactorial. Interesting. One of the things for sure, we are not as good as we think we are. Sages just presented an article that was part of the task force that looked at videos of surgeons who thought they had excellent examples of laparoscopic cholecystectomy. And guess what? They sucked. We are not as good as we think we are. And the discipline is not there. And these are people that are thinking that they're actually doing a gold standard. And I agree with you. It's multifactorial, and we actually have an entire lecture on that where we deconstructed that. So I want to just tell you where's the source code for what we're going to talk to you about today. I'm going to tell you right now, sometimes it's not the current work that is the best work. It's historical work that's the best work on this subject. And probably the best is an article that was done by Larry Way and including John Hunter and a group that looked at 252 cases of common bile duct injuries from the laparoscopic procedural route. This was in Annals of Surgery of 2003. I would suggest that everyone gets this article because this article is a treasure trove of information on common bile duct injuries that really Larry and the group did not really expand upon. What we're going to do today is that we're data mining this great paper, and what we hope to do is to provide you the information of the profile, the anatomical presentation and nature of common bile duct injuries. Now, this will not be an analysis of why. This is going to be a depiction of the what, but it is a great paper if you're interested in really learning about these. Now, there were 252 laparoscopic bile duct injuries evaluated, and that is a tremendous number. You'll find that in the Handover classification, they only had 72. The source code for this information has been drying up as it has become more litigious. And in this 252, they had operative images and notes, they had clinical records, and they had 22 videotapes of the procedure where the injury was actually conducted. No other paper has this type of correlation, and this was in 2003. Now, the patients were referred to the authors for evaluation and treatment, just like they would refer them to Jesse. And 77%, of course, were female, and the average age was 46 years old. Now, the indication of surgery varied, but the most dominant was chronic cholecystitis. 29% had acute cholecystitis. And, very early on in my career in Akron, we presented at the International Hepatobiliary Conference and showed the world that you could do acute cholecystitis patients with laparoscopic cholecystectomy also. That was back in circa 1992. So they had 29%, a minority, but a third. 2% had gallstone pancreatitis, and I'm very glad to see this low rate because we know one of the clinical situations that can cause an increase in the incidence of common bile duct injuries happens to be pancreatitis and operating on a patient with active pancreatitis, and 0.4% had cholangitis. Now, I want you to take a look at this as I move my colleagues around. Let's look at the normal anatomy. I know this is overly simplistic, but it's meant to be. Here you have the triangle of Callot. But remember, and Jesse lives here, there is a hepatocystic triangle right above that. And I can tell you, that is absolute tiger country, okay? And that's where a lot of people lose their way by getting too deep into this area. Now I want to take, here you have this cystic duct, the gallbladder. Here you have the common bile duct, the common hepatic duct right above here, the right and left hepatic ducts, and here's the left hepatic artery, right hepatic artery. And we did this to make it overly simplistic so you understand the relationship. Now, one point that I will go back in connection with Adrian's talk on avoiding common bile duct injuries. Frequently in most of these injuries, the common bile duct, a normal sized common bile duct, is mistaken for a cystic duct. And you say, well, how could that be? Well, first of all, if this angle, the Hartman's pouch common bile duct angle, is not open up, the Hartman's pouch can be stuck down here at the common bile duct. And then if you don't understand that that angle actually exists, and that one of your first responsibilities is to open that Hartmann's pouch common bile duct angle. This is what can lead to a misperception. And I wanted to make that point there. So we have an injury. These injuries are classified. Let's go over these injuries now. Now, in this particular report of this landmark article, they picked up common bile duct injuries, common hepatic duct injuries, lobar hepatic duct injuries, segmental hepatic duct injuries, and bile ducts, but bile ducts from the gallbladder bed and the cystic duct, they excluded those. Now, and I think they did that for simplicity's sake, and other classifications aren't so lenient as to throwing these out. But they did have those, but they did not really report on those. Now let's look at the different bile duct classifications. Now I was talking to Jesse, and this is where he lives. There are over 13, 14 classifications of bile duct injuries around the world. Yeah, it's that many. And you should not be surprised, because surgeons can't agree. They can't agree on anything sometimes. So you shouldn't be surprised that everybody has their way of looking at it. Now, here are some noteworthy ones. I think the Bismuth-Strasberg one is absolutely awesome, and it's the standard. Then in this paper, they presented the Stewart Way Classification, which has some shortcomings, and we'll go over that. And then I gave you the Handover Classification, which has some, it may be the most accurate, but the most laborious. And then you have people like Lau and Niehaus and others around the world. And by the way, in 2013, I believe, there was a world conference on the different bile duct classifications. And the first three of these were selected as being the most noteworthy. Now, let's look at Bismuth-Strasberg classification. Let's look at the left side here. Now, if you look up here in this area, this particular classification, class A, is about leakage. And leakage from the cystic duct here and from the gallbladder bed or ducts of Lischka. Interesting enough, guys, the first article on the duct of Lischka being visualized from the laparoscopic vantage point was from my chief resident, Tom Bryant, at Akron General Hospital when he went out into private practice. That's right, go Akron. And he actually cannulated this duct of Lischka and shot a cholangiogram with it. And this makes up what they call Bismuth-Strasberg class A. Now let's go to B. And this is something that you really have to be aware of. Jesse knows all about this. But you clip off the cystic duct, but you have a right posterior sectorial duct. I mean, and Jesse, this is one that's always amazed me, and this is one you really have to be aware of. It actually is high up, and it can come down. You have the cystic duct, but you also have a large sectorial duct here that in the course of removing the gallbladder, you will injure. And you can see it does not communicate with anything else, and therefore you can see where Houston, we have a problem. Now, in class C, we go back to leakages. Now, in B, you saw that sectorial duct was actually ligated. Here in C, the sectorial duct is open and leaking, okay? So that's the Bismuth-Strasberg classification C. Now, let's look at D. Now, D involves an injury with a leak without any loss of tissue, okay? And this is going to be D. Now let's go to the next group. And this is where I think Strasberg was really wise. You don't throw out the baby with the bathwater. You don't throw out the old to embrace the new. He went back to the classical description by Bismuth of these issues. So let's take a look at the E series of injuries. E1 is an injury to the hepatic duct greater than, or in the common duct, greater than 2 centimeters from the hilum. Here's the hilum right here. The hilum is key. So E1 is greater than 2 centimeters. E2 is going to be less than 2 centimeters. Okay, that's the E classifications with the Bismuth Strasbourg. Now let's go to E3. E3 is at the confluence in the hilum, but the left and right hepatic duct are still communicating. E4 is even higher up or more cephalad. And then you have a disruption of the confluence. And basically the stricture has isolated the left and right hepatic duct. And then now you go to the E5 where you have a stricture without any tissue loss that are varying distances from the hilum or hilum of the confluence. Now that's Bismuth Strasbourg. Now let's go to the Stewart Way. And the Stewart Way classification was associated with the anatomical injury patterns of this particular article. A class 1 is an injury which is usually lateral, as you can see here, and involves a leak, usually, without a loss of common bile duct tissue. Now, class 2 is what I call the Pac-Man injury, whereby you can see there has been clips, cautery, or both to actually take out tissue from the common hepatic duct or the common bile duct. Now, class 3 is a frank total loss of tissue that can include the common bile duct, common hepatic duct. And usually, as you see here in class 3, the proximal duct is actually left open. Now, class 4 is really pretty selective. And this is, to me, this particular classification is too simple, because now the class 4s are the right hepatic duct injuries with or without right hepatic artery injuries. So far, I'm favoring Bismuth Strasbourg because I think it really encompasses the majority of the injuries you see. And then now I've shown you Stewart Way, which in my mind is a little simplistic. And now we're going to go to the next classification. This is the Handover Classification. And I show this classification because it's probably the most accurate. You could have a common bile duct injury and have a box to put every last one of them in, but look at how tedious this is. So they isolate peripheral leaks with the A, and then they break it down to A1, A2, whether or not it's a cystic duct leak or a leak in the region of the gallbladder bed. So you see what they've done. They subsequently deconstructed this more. On the B side, you have stenosis of the main duct, usually from clips, and it can be incomplete or complete. So you see, they have a slot for every one. Then in C, they have tangential injuries, and then they choose to give us a way to classify the vessel injuries, because you do get, it's not just a common bile duct injury, you can have vascular injuries too. Then subsequently, they go to type D that has a totally complete transacted bile duct. And then they top it out with their classification E's being a modification of the traditional bismuth. So I still like, and Jesse, if you could comment now on this, and also chime in, Adrian, too. Uh, which one of these classifications do you embrace and why?
Yeah, I agree with your assessment. And so, and I have a couple slides on this. I'm not going to belabor the point, but, I was trained and I'm most familiar with, and, I think like a lot of residents, the first one you get introduced to is the Strasbourg Bismuth classification. And I think that's my go-to one. It's easily understood. It stood the test of time. I can, describe it to new trainees and discuss it with veteran hepatobiliary surgeons alike with ease. And it's the most useful for, when I'm mentally preparing myself for what sort of injury are we dealing with here and what sort of repair am I going to need to undertake to fix this injury. I think it's the most useful for that. You have a great picture of the Handover classification here. It's very thorough. It's very thorough, but is it easy to, describe all of this in a succinct way to a new trainee or even a patient if you're trying to discuss it with them? Very, very difficult. So for that reason, I lean towards the Strasbourg classification and default to that almost exclusively.
How about you, Adrian? What's your feeling on this?
I was afraid you were going to call on me on this one because I honestly don't have a favorite one. As a matter of fact, I was aware of 3 classifications and wasn't aware of the fact that there's as many as 13. But I was actually wondering through the presentation why I've never really taken the effort to memorize one of these completely. It's always something I have to go back to, and it's truly one of the, and the answer is very simple. It's truly one of those things that you don't even want to think about because you don't want to think that this could happen to you. And thankfully, unlike Jesse, I don't have to deal with them and prepare myself mentally for having to fix these on a regular basis. So my efforts have gone into prevention rather than having a favorite, and it's never really come to mind. It's like asking what's your favorite type of train wreck, That's
right. Well, you know what though? That's a natural phenomenon. And what we're trying to do here is expose people to the train wreck so they prevent the train wreck. Because knowledge is a great thing. And I just want to share with you to connect the dots as far as, okay, why are you bringing up these train wrecks books, but we don't want to hear about that. Well, the reason I'm doing this is because, as you remember with the video that we did initially on the common bile duct injury, there was a common bile duct injury committed. Now what I want to do is connect the dots and bring you back to what classification of injury that was. And that was a class 3 injury, except what happened, Jesse, on that particular one, the proximal duct was partially closed and wasn't totally open. So I wanted to connect the dots for you all out there with what you saw earlier. And this is a Stewart Way classification, class 3, all right?